Hello friends, welcome to my YouTube channel. My name is Prathamesh. Without wasting our time, let's begin. And if you like, please like, share, and subscribe.
This is a survival curve for pancreatic cancer. The sharp decline shows a bleak baseline. Survival is under 15% due to late detection. The constrained region before diagnosis is the biological stealth period, where the disease presents zero macroscopic signs, preventing early identification. By the time tumors grow large enough to physically deform the surrounding tissue and become visible on a standard imaging scan, the cancer cells have almost always spread beyond the pancreas. This late-stage detection traps clinical responses in timelines focused on palliative care, rather than the localized surgical resection timelines that could cure the patient. Shifting the overall survival probability is biologically impossible unless pathology is identified before physical structural deformation begins. The Mayo Clinic has engineered a computational model named RadMod, capable of establishing a 3-year preclinical detection window. This diagnostic leap is entirely software-based. It requires no next-generation hardware. Researchers apply a novel computational analysis directly to standard, older imaging formats. Routine CT scans already contain latent pre-neoplastic data. That information is encoded deep within the numerical relationships of the pixel density. Artificial intelligence models utilize spatial feature extraction to read these relationships, identifying subvisual tissue variations occurring well before a solid mass forms. Extracting these quantitative anomalies mathematically bypasses the biological stealth period. In standard clinical workflows, radiologists analyze abdominal CT scans by searching for explicit structural deformations, protruding masses, or dilated ducts. The human eye has strict computational limits regarding contrast sensitivity. We cannot parse minute grayscale gradients across a uniform field. A standard abdominal CT slice is a mathematical grid of discrete three-dimensional voxels. Within this cluster of voxels, the tissue appears homogenously gray to a human observer, yet the raw numeric values vary from voxel to voxel. These numeric variations correspond to biological events in the tissue microenvironment, specifically microtexture alterations and pre-neoplastic density changes. Because these localized density changes do not disrupt the macroscopic shape of the organ, they do not trigger human pattern recognition or flag as anomalies during an exam. Critical early warning data remains mathematically distinct from the visual image, rendering it inaccessible to human biology. To process this high-density voxel grid, researchers deploy a convolutional neural network architecture. The network slides mathematical kernels across the tissue matrix, executing localized multiplication. These kernels extract spatial features, mapping texture variance, edge gradients, and density into distinct layers. The network then processes them together as a high-dimensional data tensor. Within this tensor, the model hunts for signatures of early desmoplasia, or localized tissue stiffness. This algorithmic process is an analysis of statistical variance, rather than a simple magnification of the image. The model measures these extracted statistical deviations against a massive baseline of healthy tissue norms. These algorithmic deviations remain detectable years before the physical genesis of a dense tumor mass. Deep learning shifts diagnostic imaging away from subjective visual shape recognition, converting it into quantitative structural analysis. Establishing these predictive timelines requires training the AI on retrospective longitudinal datasets. The core methodology involves analyzing older, technically clean scans of patients who eventually developed clinical PDAC. By correlating the diagnostic scan at year 0 with a scan taken 36 months earlier, the model isolates precursor signatures. A human radiologist assesses the older scan as having no findings, while the AI identifies a localized diagnostic heat map on that exact scan. Clinical trial results from the Mayo Clinic confirm this repeatable isolation of pancreatic cancer risk up to 36 months prior to clinical onset. Bridging this massive lead time alters the clinical response pathway, providing the runway needed to move from palliative management to active localized intervention. Time is the primary clinical variable manipulated by this retrospective computational approach. These models are moving into the clinical integration phase, entering large-scale applications like the upcoming PACE clinical trial. Deployment relies on opportunistic screening within high-volume hospital radiology workflows. A routine CT scan taken for an unrelated issue, like a kidney stone, is automatically routed through an AI background screening node before reaching the standard radiologist queue. Running these background tensor checks demands high computational efficiency, but incurs minimal marginal cost, requiring no additional human clinical hours. Because the deployment is software-based, it scales globally. This allows rapid penetration into resource-strained healthcare networks, like those managing dense populations in India. Opportunistic AI screening shifts hospital infrastructure from a system of reactive diagnosis into one of continuous, automated background monitoring. Returning to the epidemiological baseline, the standard late-stage diagnostic window dictates the sub-15% survival rate. We plot the verified AI-driven early detection coordinate exactly 3 years left of that standard window. This intercepts the disease state before metastasis, expanding the localized surgical intervention window and creating a mathematical increase in the survival curve's area. Securing this localized surgical window creates the potential to push survival probabilities significantly above historical norms. Computationally bypassing the stealth period is required to invert the PDAC mortality rate. High-dimensional spatial feature extraction yields actionable preclinical data. The logistical superiority of this approach rests on utilizing existing standard imaging infrastructures. It requires no new hardware acquisitions. Machine learning identifies biological indicators that human vision cannot perceive, representing a fusion of computational engineering and biology. In practice, the Mayo Clinic model functions as a continuous, invisible safeguard against previously undetectable pathologies. Algorithmic feature extraction provides the definitive diagnostic resolution for Pancreatic cancer carries an exceptionally high mortality rate, almost entirely because of when it is diagnosed. By the time symptoms prompt a doctor to look for it, the window for effective intervention has usually closed. This chart outlines the diagnostic reality. 85% of cases are caught in the late stages, after the malignancy has already spread. Because of this structural delay, the overall survival probability drops to less than 15%. To solve this timing failure, researchers at the Mayo Clinic developed a highly specialized artificial intelligence model called RadMod. The system identifies a high probability of pancreatic cancer up to 36 months before any anatomical tumor develops. It achieves this 3-year lead time without requiring new, specialized hardware. It runs its analysis entirely on standard, archived CT scans that a patient has already taken. Moving the detection window backward by 36 months shifts pancreatic cancer from an advanced systemic crisis into a localized, proactively manageable condition. This creates an immediate clinical question. If a human specialist and an algorithm acts as a digital magnifying glass, locating microscopic tumors that a doctor simply missed, that is incorrect. The human visual cortex evolved to recognize macroscopic patterns and defined boundaries. When doctors evaluate medical imaging, they are inherently searching for structural anomalies, a mass, a lesion, or an obstructed duct. RadMod succeeds by bypassing macroscopic anatomy and evaluating the scan as a high-density matrix of raw mathematical data. The algorithm scans for microscopic shifts in the texture and microarchitecture of the pancreatic tissue. The system's predictive power resides within the CT scan's underlying identity as a vast computational grid. At its core, a computed tomography, or CT scan, is an instrument of precise physical measurement. The visual image a doctor looks at is just a user interface built on top of the actual dataset. The true output is a massive 3-dimensional grid. Every tiny cube of tissue, called a voxel, is assigned a specific mathematical value representing its exact radiodensity. This density is measured in Hounsfield units, or HU. The scanner calculates exactly how much X-ray radiation is absorbed by every single millimeter of the organ. Distinct biological materials have strict Hounsfield unit signatures. Dense bone registers highly positive values, air measures as deeply negative, and soft tissues like the pancreas hover in a narrow neutral range. The human eye has notoriously poor contrast sensitivity when forced to differentiate between dozens of nearly identical shades of gray within that narrow soft tissue range. Even when the underlying data reveals sharp fluctuations in radiodensity, our biological hardware processes it as a smooth, uniform gradient. To any human observer, the tissue looks perfectly healthy. The earliest biological indicators of a developing cancer exist exclusively within these imperceptible numerical variations, rendering them invisible to human doctors regardless of their diagnostic expertise. To process this hidden numerical landscape, the AI utilizes a specialized computational framework known as Radiomics. Radiomics is the algorithmic extraction of high-dimensional spatial data from medical imaging. The system deploys convolutional neural networks. These are mathematical filters that slide incrementally across the localized Hounsfield grid of the pancreas. Rather than simply reading individual values, these filters calculate complex spatial relationships. They measure how the density of one voxel interacts with the dozens of voxels immediately surrounding it. Through this process, the AI constructs abstract texture maps. It maps areas of spatial heterogeneity, regions where the numerical jumps between adjacent pixels are mathematically erratic. It isolates exact mathematical anomalies, mapping abnormal pixel clustering and steep density gradients that break the statistical rhythm of healthy tissue. These extracted maps combine to form a highly intricate mathematical fingerprint of the organ. It is a strict quantification of the tissue's physical state, completely disconnected from human visual interpretation. What physical event is occurring inside the patient's body to trigger these mathematical anomalies, a full 3 years before a tumor materializes? Long before mutated cells replicate enough to form a solid mass, the pre-cancerous tissue experiences severe microarchitectural breakdown. During this 3-year window, the pancreas undergoes localized inflammation and desmoplasia. Connective tissue begins to scar, stiffen, and undergo heavy fibrosis, becoming spatially chaotic. As the microscopic structure of the organ becomes rigid and scarred, its physical ability to absorb X-rays changes. This localized scarring disrupts the uniform density of the surrounding healthy cells. It scatters the localized Hounsfield unit values, generating the exact spatial heterogeneity and erratic texture maps that the algorithm detects. RadMod identifies the specific microscopic environmental deterioration that inevitably precedes the formation of a malignancy. Transitioning this algorithmic capability from a research server to a hospital floor relies on a clinical workflow called opportunistic screening. This strategy completely bypasses the traditional diagnostic timeline. Patients do not need to schedule a specialized oncology appointment or undergo a preemptive cancer screening to be evaluated. Instead, the AI operates in the background, continuously analyzing historical, non-targeted CT scans. These are scans ordered years prior for entirely unrelated issues, like generic abdominal pain. If the algorithm detects the mathematical fingerprint of precancerous fibrosis on an archived scan, it automatically flags the patient for active, high-frequency monitoring well before any physical symptoms arise. Opportunistic screening reclaims dormant hospital data and converts it into a continuous, active, early warning intelligence network. The RadMod technology has moved beyond retrospective data validation and is currently entering active clinical trials. Over the next few years, these trials will scale across major hospital networks and global health systems, systematically expanding the dataset and refining the algorithm. This deployment marks a distinct structural transition in modern oncology. The entire field of oncology is shifting toward proactive computational forecasting, moving well past the limitations of reactive anatomical diagnosis. The raw biological data required to anticipate and survive this disease has been flowing through our medical hardware for decades. Now we finally possess the computational architecture